All right, we're going to surprise somebody by, Mark, you want to read the mission statement for us?
I sure will. Thanks, Phil. Macomb County Community Mental Health, guided by the values, strengths, and informed choices of the people we serve, provides quality services which promote recovery, community participation, self-sufficiency, and independence.
Thank you. Next, I will take a motion to adopt the agenda. We have one item that is revised, and that is the proposed budget. Other than that, everything else is the same. Take a motion to approve.
So moved. Support.
Motion from Linda, support from Lori. Questions, comments on the agenda? All in favor signify by saying aye.
Aye.
Aye. All opposed? Agenda is approved. Next, we'll move on to hearing of the public. Anybody from the public wishing to speak on any item on the agenda? You have 5 minutes. Anybody wishing to speak? All right, nobody's jumping up. We'll close the first hearing of the public. There's a second before the end of the meeting. And we will move on to item 5A, request approval to move to CMH full board for final approval E&M code increase. Take a motion to approve.
Motion to approve. Support.
Motion from Lori, support from Selena. Dave, go ahead.
I've mentioned this item previously, but it's now finalized. E&M codes are the evaluation and management codes. These are specific. What we're proposing the increases for are the psychiatric services. So if you recall, we've done an across-the-board 8.62% increase for all the outpatient codes. These codes were left out. The increase is intended to help with the capacity issues on the provider side, so that they'll be able to hopefully recruit psychiatrists either in person or through telepsychiatry services at a more attractive rate.
I'm going to turn it over to Dana.
I'm so sorry, everybody. Traffic was terrible, so sorry. Okay, so I take it we already had motion and support.
I'm looking for questions, comments.
Okay, any other questions or comments? Nick?
Just, I don't know if you have an answer to this, but what's the, how does this compare with the surrounding CMHs?
We did look at that, and we looked at what the various telepsychiatry services we're going at locally. Actually, Tracy did that type of assessment. On the lower side, it turns out to be about $200 an hour, so that's where we moved it up to. There was some work involved because not all of the E&M codes are based on 1 hour. Some are based on 45 minutes and things like that. So finance helped do those adjustments, and we're able to get those completed.
So we'll get closer to being competitive?
Yeah.
Okay, any other questions or discussion? All in favor?
Aye.
Any opposed? Okay, let's move on to item 5B. I'll take a motion to request approval to move to CMH full board costs surrounding the painting of the north location. So moved.
Support.
Okay, TJ?
Yep, very good.
Good evening. This is for painting of the interior of the north facility. That is our flagship location, and we're going to some great lengths to improve both the exterior and the interior of this. This is the first act that reaches the threshold for board approval. We've made some other changes that have not met that financial threshold that we've moved forward on. But this particular one, almost $15,000, is, I think, a good price, and we've vetted the other contractors for this particular job, and I think that this is the vendor we would like to go with, so pending your approval.
Okay, thank you, TJ. Go ahead, Donna.
I noticed on the diagram when you painter that A, B, C, D in the order they were going to be painting, and I noticed It wasn't the entire facility.
That's correct. It's just the common areas, the hallways, the cafeteria, the group rooms, the lobby. No individual offices are being painted. The facility was last painted about 6 years ago, all in a standard neutral color. And we are going to use 4 different colors, all calming, nothing bright orange, earth tones that we selected for these that help us identify different areas of the building as well. As we move forward and the traffic patterns change there, we are making some significant changes in where we're placing individuals. This will help identify those portions of the building as well.
So
But-
all of the companies was based on the same area?
That's correct. Apples to apples.
Okay.
Yep.
Thank you.
Okay, any other questions? Okay, all in favor?
Aye.
Any opposed? Okay, thanks, TJ. I think you're gonna be up next. Can I do C through F together, or do we have to do one at a time? Okay,
They're different locations.
you want me to do one at a time?
Sure.
Okay.
Can I ask that you put your microphone on?
I can't hear you over here.
You guys can't hear me? I am super loud. Okay, is that better?
Yeah, well,
Okay. All right, sorry, guys. Let's move on to item 5C. I'll take a motion to move to CMH full board for final approval, residential lease A.
so moved. Support.
Okay, TJ, is this you?
This is me, and unless you have any other questions, both the provider and the landlord, and to save a bit of wind in this lease and the others that are up next, have all completed the assigned tasks in order for us to bring this lease to you. They have all been completed.
Go ahead, Linda.
When you finished your sentence, you said to bring these two, are there 4?
There's a total of 4 leases
So
before
the
that are
4.
coming up. Yeah, we're only doing one at a time, but
Sure, but all
They're all-
4,
yeah.
That applies to all
Right.
4. Thanks. Any other questions or comments? Okay, all in favor? Any opposed? All right, let's move on to item 5D, request approval I'll take a motion to request to move to CMH full board for final approval, residential lease B.
So moved. Support.
Okay, TJ?
The same thing stands.
Okay.
Just so you know, I will not bring a lease before you unless those projects have either been completed, those that are signed, or at least scheduled if they're large-scale projects, that we have a hard date by the landlord or the provider to complete them. So,
Okay, any questions on this one? All in favor?
Aye.
Any opposed? Okay, item 5E, request to move to CMH full board for final approval, residential lease C.
Support.
Any questions or comments on this? All in favor? All in favor?
Aye.
Any opposed? Okay, 5F, request, I'll take a motion to move to CMH full board for final approval, residential lease D.
So moved.
Any final comments, TJ?
I would like to make a final comment.
Okay.
These were all 2-year leases that are unlike the ones we've approved previously that were at 5 years. We've given our providers and our landlords notification that we are only renewing for a shorter period of time in hopes that we move out of the real estate business and we have our providers lease directly from landlords, whether the home that they're in or a new home that they're looking for. 12 years ago when I started, we had 122 homes. We're down to 84 homes now. So a lot of homes have been shed from our rolls. A lot of those have moved to either unlicensed settings, which are fine, or that providers have found a different home to live in, and we continue to encourage that every step of the way, that as much as possible.
Okay, thank you. Any questions or comments? All in favor? Any opposed? Okay. Thanks, TJ. Thank you. Item 5G, I'll take a motion to move to CMH full board for final approval. Request an RFI, request for information for engagement center programming. Okay.
Good evening. Hello. Here to get your approval. We want to move forward with issuing a request for information for our engagement center. So if you're familiar with an engagement center, that's a place and a location where an individual under the influence of a substance can come in. They generally are working with peers in recovery, and they're given a place to rest if they need it, food for the day. They can take a shower. But the real goal with this is to get people a safe place to be so that rather than being picked up and sent to jail or taken to an emergency department where they really don't need to be at the time, but maybe there's nowhere else for them to go, that they would have this safe location and place to be. Part of what's important with an engagement center is that we have our peer professionals there working with the individual to try and help motivate and educate and offer resources for them. And ideally, help link them with services, our treatment services or other recovery services for them. So by the time they leave after a day, if they stay the full day, then they have a recovery plan in place to take with them. We're hoping to open this up under Macomb County Community Mental Health. We want it as part of a full continuum of crisis services that we're doing. But for this, we're looking to see about having some substance use agencies provide the staffing for the project. And issuing it as an RFI would give us that feedback that we might get to kind of come up with some unique ways of presenting this project.
Okay. Thank you, Helen. Is there any, go ahead, Linda.
I'm thinking of back when I was a worker and 5 o'clock on Friday afternoon, somebody in the back of my car before car seats, kids. What's the plan? Things don't just end at 5 o'clock with a happy ending. So,
Right.
And I'm sure licensing doesn't let them stay longer or all night.
So an engagement center isn't a licensed facility. It's not a licensed treatment program, so we don't need to follow under that piece. We would take in people who meet all of our criteria for the staffing piece of it, but it's a 24-hour facility. So 7 days a week, any time of the day, somebody can come. They are screened prior to coming in the door just for a little bit of safety check, because you also have to make sure they're not somebody who really does need a medical emergency type situation. So some brief questions are done just as a screening, or it can be done if they show up. If something more intensive is needed, they'll get them out to where they need to be. But as I mentioned, it's primarily staffed by peers. We would have somebody with the ability to take vitals on staff so that we do blood pressures and breathing checks and things like that just to make sure something doesn't go wrong. And in that case, we'll have agreements with, local emergency or urgent care centers based on the need for that. Yep.
Thanks.
Yeah. The CNA is a requirement minimum to be met for medical staff, so we don't need to have actual nursing on staff or a doctor on staff because it's not a detox facility. It's, a place for somebody to come and just kind of settle down and rest and kind of regroup and make some plans. So if somebody is in need of like withdrawal management or anything to that effect, we would coordinate and connect them with the services for that. We would have a relationship with some type of medical provider in case we're seeing issues that we could consult with and therefore potentially make referral to. That's part of the overall plan for this. We do have a consultant working with us. She's opened up 4 different engagement centers in other parts of the state. And so she's quite an expert on this. And so she's worked with us. We've gone on tours with her and visited other centers, learned a lot, helping develop our policies and procedures and all the safety protocol that go into place with this service as well. Yeah.
Donna?
So how would you mostly have people come into referrals, or how would you get, people to know about the engagement center?
So I believe it's going to depend on, how it grows over time. Initially, it's more likely going to be individuals, word of mouth, word on the street type thing. We really are going to market with our first responders, our police and sheriff, so that they're aware of this service is available. We really want to connect with our local emergency departments because we already have a good relationship through our contract with CARE, who goes in there with our peer recovery coaches for our Project Assert. Many times people go there, but they really don't need a medical level detox or withdrawal management at that time. And so this would be a better place for them. So it could be a diversion for the hospitals. It happens a lot that way. Depending on the communities from the other ones that we looked at, it's kind of like a 50-50. 50 community just on their own, they know about it, they come through, and another 50 from either hospitals or law enforcement.
Okay, any other questions or discussion?
I just have a comment. I'd like some more information as you go along. I'm
Sure.
watching Selena and Mark particularly, the idea of who goes and how they stay and what condition they're in when they get there and all of that, so.
Yeah, there's a
I'd like
lot
s-
of great protocols coming that we'll have in place. We'll be really happy to share.
Right.
Safety is the first thing. But this is kind of done in a lot of different places. Some of you know of Dawn Farms and other places. They've done like social detox withdrawal. It's not even really at that level. It's really somebody a lot of people under the influence of alcohol coming and having a place to kind of let that alcohol dissipate, and then they can go about the rest of what they need to do when they leave the facility. But unlike being, I'm on the streets and somebody sees me intoxicated, they pick me up, they're going to take them to the hospital or jail. That's what's going to happen right now, because in our community we don't really have anywhere else for them to go. So this would give that safe place and a more appropriate place. We really want to stop using emergency rooms for where it's not needed. That's not, a good resource, good use of that resource. And we also want to keep people, from going to jail when they don't need to do that either.
Thanks.
Selena?
And I'm very familiar with what you're talking about. It's also called a living room setting, so, they kind of just go in and hang out. Are you going to be actually taking are the police going to be able to drop folks off to you?
That is allowable under the model. It's going to depend on what the comfort of our police departments are. Some might be more comfortable in doing that type of service. Some might be more concerned that, no, they can't take that approach. But we're really hoping, too, that this, as part of our crisis continuum of care, I'm sure Dave's mentioned to you before about some of our goals with jail diversion and other pieces. We're hoping that this will work in and just be one of those natural pieces of our jail diversion as well. So, even if they do get picked up, rather than being, put in jail, it could be part of the diversion before it even occurs.
I think they're going to have a lot of education on the police department's
Yeah.
role, because a lot of times they don't want to make that call.
Yes, they don't feel like that's something that
That is
they
out
can
of their
do.
wheelhouse, and so it is
Yes.
automatically always going to be that emergency department, and that is where your key to success is going to be, because we're going to get in there, we're going to triage them,
Yeah.
and we're going to find that medically, they're stable, behavioral health-wise, they're stable, and this is not the right setting for them.
Right. That was one of the things our consultant spoke to us about, because in one of her communities, they developed a really great relationship with their local police department. And it took time, but it really grew into something that they had that comfort in being able to do that. So, we'll start in one spot and we'll keep it growing. And I think as it ties into these other pieces, that should really be, give us a lot of opportunities to help people.
Go ahead, Linda.
For those on the board who were around during UBHC, part of the failure of that program, which was gigantic, was they didn't educate, and it's not just police department in Macomb, it's police departments and the
Yes.
sheriff offices and all the little municipalities and everything. And they never bought into it. They never, ever knew anything about UBHC. They never took a person there. They, the jail was familiar to them and easier and on the main route.
Yep.
So marketing is going to be a big part of it to be
I agree.
successful
Yeah.
with the police.
Yeah.
And training, of course. Yeah.
Right. And, we, depending on where it's going to be located in the end, because it's still to be determined, might depend on which departments are more willing to work and, where we'll probably start more of
Sure.
our efforts. We're really looking at where the highest needs are, looking at the data for that as well, and those are really going to be our target areas too.
Well, they're all real good driving them to Groesbeck and Elizabeth, so.
Yeah.
Okay, any other questions? Go ahead, Mark.
Comment. I think one of the issues or obstacles we may face with that is the police department's being understaffed as well. And if it's too far away from where they're at, they're gonna say, I can't afford to have an officer drive all the way out there and wasting the time, because that's the way they're gonna look at it.
Yeah.
So I think location can be really key. And we know a lot of the biggest activity areas are in the southern part of the county.
Right. Yep. We do know that, yeah.
And I work well with a lot of police departments already, so.
There we go, we got a little in. I like that, Mark.
Okay, any other questions? I'm going to call on myself. I have a couple questions.
Sure.
Thanks, Linda. Where has your consultant set up centers like this? In the state of Michigan or other?
Yes.
Okay.
So she's done it in Jackson, one in Washtenaw, one in Lansing area.
Okay,
Jackson,
and
Ann Arbor,
they've been
Washtenaw, there's one
successful?
more. Yes, they've been successful. There's two different models that have been used. The living room model has been less successful than the 24-hour facility. So the living room model, the way it was set up in the other areas, wasn't staffed during, like, let's say, regular business hours. It was more an after-hours facility. So we've decided right from the beginning we want to be a 24-hour, plus our grant that we have requires a 24-hour availability. So we thought that went well together because that's what we wanted to do, and now we even had the grant recommending that, that's the approach that they want to see taken. Because you don't want to have people say, well, can I go now? Is this the day it's open or not? Police aren't going to bother with that. The hospitals, that's going to be too much for them as well. And the community at large. So, we just want to know, nope, anytime, this is, the approach that we can take. We'll be here.
Okay, any other questions or discussion? All in favor? Aye. Any opposed? Okay, thank you.
I think I'm the next one.
Oh, you got the next one too, so you might as well hang out.
Just stay here.
Okay, item 5H, I'll take a motion to move to CMH full board for final approval. Approval to issue an RFI, request for information for recovery housing services for women with children.
So move.
Okay, Helen?
So we did receive some grant funds to allow us to operate or purchase services for women who have young children to have recovery housing services. So right now we have many different recovery houses for people 18 and older, but they don't allow children in. They're just a single person that can come at a time. And so we do have women's specialty services in our county. We have Sacred Heart Clearview, where pregnant women and women with young children can go have their treatment stay. But when they leave, we don't have anything in our community to offer to them if they don't have safe housing to return to. So the goal here would be for us to issue a RFP, see if we can't find a suitable provider that's interested in providing that service for us in the county, to be able to offer this to the people that we serve. Our current panel of recovery home providers, none really had the interest or the space at this time to do this service, so that's why we're looking to expand our panel and see if we can get this specialty service in place.
Okay, any questions or discussion on this?
Of course, I have something that's about recovery. Is this going to really open up a lot of the issues they don't want to do it because some be liability for having children in the home?
For some of the providers, first of all, most of our providers are reluctant to serve women.
Mm-hmm.
There's more issues in a women's home than they have in some of the other homes. And our providers, there's different levels of certification you can have as a recovery home through the Michigan Association of Recovery Residents. And so they're not that top layer 4, which is like a professional staffing level. So many are just people in recovery. They don't have a full-time at-the-home manager. They're in on the evenings looking for check-ins and different things. So this model does require that more intensive staffing. So a little more costly because you have higher staff cost. Some may be concerned about liability. There's some programs in other counties that have this, and for those programs, that's not their concern or issue. But I think it's just depend on, who has the passion for this, and then who has the interest in doing it and starting up a new project.
Thank you, Helen.
Okay, any other questions or discussion? All in favor?
Aye.
Any opposed? All right, thank you, Helen.
Thank you.
Item 5I, I'll take a motion to move to CMH full board for final approval, Azara Healthcare DRVS agreement. Dave?
Tracy? No. So Azara is the electronic medical record used by all of the federally qualified health centers, or FQHCs, in the state of Michigan. It's also a population health data platform. And in our work with MyCare, we were able to get a kind of a glimpse at how it was used. They're very happy with it. So then at the state level, I learned they were doing a pilot project with PCE, who is our current electronic medical records vendor, and Azara to start sharing information between those two. And they were limiting that to 3 counties. I reached out to the folks at the state initially and said, hey, we're interested because, of course, we're doing our CCBHC program with MyCare, and any data sharing, would be, I think, incredibly helpful. So the state, of course, did some changes, but John Villacerta, who was he was point on the CCBHC programs, before he left the state, was kind enough to put Macomb County into the planning process, and we are getting funded to cover the license for the Azara platform. So Lindsay is the new point person for that. So we've had a couple of follow-up meetings and things, but what we're looking to do is enter into the formal licensing agreement with Azara, which will give us access then to better coordinate care between the physical health care, behavioral health, give us access to another data source that we might be able to use. Let me look at what, yeah, it's just right now it'll be primarily between us and MyCare, but we might be able to expand its use, of course, as we go forward. And again, it will be covered, the licensing costs will be covered through a special grant from the department.
Okay. Any questions or discussion? All in favor?
Aye.
Any opposed? Item 5J, I'll take a motion to move to CMH full board for final approval, the AFIA contract renewal. Who's
We have
got-
Rachel here to speak on this one.
Good evening, everyone. I'll introduce myself because I haven't had the pleasure to stand before you. My name is Rachel Angary. I am the Director of Clinical Informatics. The contract that's up for renewal is with AFIA. We've worked with them for a couple of years, and some of the modifications to the contract include an increase in their HEDIS hours, increase in training hours as my clinical informatic team grows, and as our needs as Macomb grows as well. The Ncqa Certification, this comes in 2 parts. The total cost is $15,000, but in the future it is only going to be $5,000 because we're back paying $10,000 that wasn't in the budget before. And then we are going to get additional users, which include designers and viewers, which is exciting because that means there are more people using the data that we already have, and an increase in in the cost of the nightly backups, which is security, storage, and issues as they arise.
Okay. Any questions for Rachel? Any comments, Linda?
Doesn't anyone want to know what informatics is? Am I the only one?
When we talk about informatics in a clinical sense in healthcare, it's using all the data we collect, how many patients we see, what their diagnosis is, when they come to us, how many times they've been hospitalized, and it's all that information and using it to analyze it so that we can get better at serving our clients. So if we're able to look at John Doe is always at the hospital at the end of the month because, you know, that's when he gets paid, that's when he gets drunk. So we can start working on what is our data telling us so that it can influence how we serve him. Does that mean before the end of the month, the case manager reaches out and all that? So informatics is just using all these tools, all this data we've always collected, just making it better to serve our clients better.
And then I assume the workers have to be trained to be able to fine tune the
Yes.
search rather than, we always look at the big picture or the overarching statistics and so forth, but.
Exactly. So as the clinical informatics teams grows, as looking at how we enter our data, because that's a big thing, because if it's dirty in, dirty out, it's what can we change about our workflows that make our work better, and then it's moving farther out. So how can we change how many people, how can we increase our penetration rate? Does it mean reaching out to people on this? If this worked, how well did it work? What are the statistics behind it? And what changes can we tweak to make our work better?
Thank you and welcome.
Thank you.
Phil?
Thanks, Dana. All this data, is it stored on site, in a cloud, all the above? Is it a Thomas problem? Is it a FIA problem? Who's in charge of all of that?
We
So-
can't tell you.
I retract the question.
It's a two-part. So we have our focus data is stored with us. We have servers. Their FIA is stored on their server, but we have access to it as needed for both.
Thank you.
Okay.
Thanks, Dana.
Just, if I could too, Rachel, I know you presented before and stuff, but Rachel came to us, her background is an emergency room nurse, who then, in her free time as an emergency room nurse during the pandemic, went to and got her master's in informatics. So we're very happy to have her, and we are working diligently on our data, and it's really getting the useful information in front of the right people at the right time to really impact the service delivery for those individuals. So thank you, Rachel.
Thank you.
Okay, any other questions or discussion? All in favor? Aye. Any opposed? Okay, thank you, Rachel, welcome. Okay, item 5K, I will take a motion to move to CMH full board for final approval, the 2023 fiscal budget.
Oh, that's nice.
As revised, did I say that?
Depending on what Richard tells us.
Okay, did Phil make the motion? Did I hear a second? Okay, thank you. Richard, it's all you.
Yeah, so again, revised, should be in the packet. I will point out the revision first, just so that everyone knows we did make a small change on, it is page 5. It says page 5 at the bottom. So really the only change here is that we noticed that when we applied some of our trending to the revenues in our budgets for 24 and 25, we did apply that to the county general fund appropriation amount, and that number should stay the same every single year. So that's the only change from what was originally in your packet to what is before you today. Is we cleaned that up a little bit to make sure that that was consistent and in line with what the county executive's office was expecting for us to present. That being said, what I'd like to do tonight is walk through some of the assumptions, so some of the key assumptions and key points related to the budget, how we built the budget, and then we'll talk about the numbers a little bit. So number one, the Medicaid and Healthy Michigan plan revenue is currently based on projections from the Michigan Department of Health and Human Services. At this point, MDHHS had indicated an expected net decrease of about 0.9% related to Macomb County specifically. The state actuaries were including actually an increase in the number of eligibles that we were expecting. So the way that that was working is as the number of eligibles increases, the rate comes down, right? If they don't expect our expenses to follow that. So they were expecting that. We are thinking that the number of eligibles are actually not going to increase as quickly as they are thinking they're going to increase. Part of that is because we do expect the public health emergency to end at some point during 2023. And so at this point, we have built in a 5% reduction in revenue for 2023. Now, as I'll mention in a little bit, we don't expect that to impact our expenses because part of the reason why we have so much money in 2022 is the number of eligibles we have. So some of this is just kind of correcting for some of that. I will say that last Friday we did have a meeting with the Michigan Department of Health and Human Services about the final rates, which were not published until today. So there is a possibility that that will change a little bit. I don't expect it to be a significant difference. I will be doing an analysis between today and in 2 weeks when we do the final budget, but I don't anticipate a revision to be necessary at this time. The second bullet under Medicaid and Healthy Michigan is just confirming that at this point in our projections, we're not planning on needing to use any of the Medicaid ISF for either 23, 24, or the 25 fiscal year. So at this point, our 3-year forecast is financial stability at this point, which is good news. Item number 2 on the Medicaid and Healthy Michigan expense side, we do anticipate some new expenditures as we continue to grow this CCBHC, or the Certified Community Behavioral Health Clinic, especially as it relates to some of our designated collaborating organizations, or DCOs, that we're bringing on board. So just as a little bit of a context, in 2022, we've started those contracts. Some of them were signed in February, some have been signed relatively recently, so kind of a middle of the year onboarding for some of those DCOs. Whereas in 2023, we expect more DCOs to come on board, and we'll have a full year of DCO costs. So what that does for us is it really helps us get more into the mild to moderate population, which we'll talk about a little bit, but there is some additional cost related to that. So we have built that into our budget assumptions. Item number 3, as we talk about the non-Medicaid, so our Cmhsp contract, the budget for 2023 is actually decreased by $177,000. For those that may have participated in the Community Mental Health Association advocacy around this over the last 5 years, there was a push to rebase the general fund contract revenue across the state. And so this is the final of those 5 years rebasing. So that new reduced amount of $7.4 million is what we would anticipate the future revenue to look like for general fund. We do continue to plan to use state general fund dollars in 2023 for provider stability as needed or other improvement plans until the public health emergency ends, and at which time we will have to consider the impact for our spend downs. So again, a reminder that during the public health emergency, individuals do not fall off Medicaid. They're automatically eligible once they get eligibility. And so what that means is that for anybody who would be in the spend down category, we're not using that general fund dollar today to support that. So, but that will end at some point during 2023. So we're planning for that in the budget. Item number 4, Substance Abuse Prevention and Treatment Block Grant Program. Right now that revenue is based on the allocations that have been communicated to us from the Michigan Department of Health and Human Services, and we have in our eGrams budgets that we put in. And then just a reminder that pretty much all of that funding is spent through services provided through our provider network. However, we are seeing under the CCBHC expansion that some SUD services will be provided internally by staff. So that is part of the required services under the CCBHC demonstration. Item 5, when we talk about the county appropriation and the Public Act 2 funding, the county match is budgeted at the 3.7 million, and so we expect that to be pretty consistent year over year. And then we use that to do a few different things. When we do the local match drawdown payment that we do make to the state of Michigan, so we pull down some of that Medicaid by providing a local match for the state. We have our GF contract match that we use that for. And then we do have the local portion of state-provided inpatient services that we have to pay for on a monthly basis. PA2 is budgeted as approximately 3.6 million, and right now that's based off of an estimate provided by the Michigan Department of Treasury. So just a reminder, PA2 funding is collected at the state level. They remit it to the county. The county gets to keep 50% for the general fund, and they have to remit 50% of that to the coordinating agency, or in this case, Ncqa. And so that 3.6 million is based on that state of Michigan projection. It's actually nice this year that they were able to get us that projection before our budget was due. Last year we had to kind of guess at what we thought that would be because it did not come until October. And then just a reminder on page 2, the final bullet under that, PA2 may not be used on administration, PHP administration, and it's the first purpose of that is to match some of our block grant funding that we get through the state of Michigan. There is a 10% match requirement. Grant revenues, just so that the board's aware, so under standard cost allocation, we're transitioning to not using a separate grant fund. So it is all the grant funding, unless it's specifically SUD and it stays in the Ncqa fund. The rest of the CCBHC funding that we had, and then also some of the mental health block grant funding that we receive, is running through the mental health fund. So that's consolidated in this budget and going forward. And then some general expense assumptions for the budget. Payroll-related costs are included based on currently filled and vacant positions. So we are budgeting for the vacant positions that have not been filled yet. And at this point, we're budgeting at the high point of the range. So we would anticipate, as we continue to grow, that there'll be plenty of budget for those positions as needed. And then all non-payroll related costs are assumed at a 1.5% increase per year. So that's going to be our supplies and those types of things. We also have built in some of those rate changes that Dave mentioned today, the EM code rate changes. All of those rate changes that have been approved for this fiscal year, we have rolled them through for the entirety of next fiscal year as well. That is the assumptions in a nutshell. Any questions on the assumptions before we jump into the dollars?
Nick, you have a question?
Yeah, go back on the county revenues that we're an agency, not an authority. Why are you assuming that they're flat?
At this point, the assumption that they are flat has to do with our assumption that our GF revenue is going to stay flat, and so the match will remain flat. So we expect all of that to be really consistent year over year.
Oh, okay. So I got you.
Yep. Any other questions on the assumptions before we jump into some of the numbers? All right. So looking at page 3, this is just walk through kind of the format here. This is all funds, so this does include both the mental health and the Ncqa fund, so in total. So it gives you a little bit of a kind of what we planned on for 2022. That first column is the original, what we're proposing for 2023, and then 24 and 25. So just really quick, as we look at total operating revenue for 2023, we're looking at about $267 million that we're anticipating in revenue, and the big changes are going to be on the Medicaid and Healthy Michigan side, where you are seeing decreases there. And then on the expense side, we're budgeting to utilize those funds at the same level, so about $267 million. And the adjustment is running through the provider network services contracts. So again, what we've done in the past is, even though we're not using all of that provider network budget currently, we budget the remainder of our Medicaid and Healthy Michigan into that provider network line item. And the primary reason for that is so that we can use that for stability funding or other special projects that might come through. Go ahead.
So we're seeing an actual surplus, but you're showing deficits in the budget, and that's because you've rolled those surpluses into the provider network services? Is that what I'm hearing you say?
So, well, deficit before investment income, but actual net income would be budgeted at zero, so our revenue
Right.
is equal to expense. But what we do is we assume that any revenue we're going to receive from the department, it will try to use that in either provider stability or other rate increases. And so the budget assumption is that that's where that
So
surplus
the
is budgeted.
pre-investment income deficit could be end up actually being a surplus. It's a budget issue, it's not a
Correct.
actual issue.
Correct. That's exactly correct.
One of the things I'm concerned about, and maybe I should have asked this under the assumptions, is what we're hearing in terms of state dollars. And I guess one of the concerns we've always had is as we left the medical emergency issue, we'd fall back into the funding crises that we've had in the past.
In the past. Mm-hmm.
One of the assumptions I think I heard you say is that as our number of reimbursables, number of people eligible, Medicaid eligible, goes up, the rate goes down.
Right.
We've been concerned, Dave's raised it many times, about our penetration rate and have been making a lot of effort at increasing our penetration rate because we think there are a lot of people out there who need services who aren't accessing them because they don't know about us or for whatever reason.
Right.
So if our penetration rate goes up, then that rate reduction is problematic. Is that a problem we're having with Millman's assumptions already? And is that a sort of a red flag of where we're going to have arguments with them in terms of the rate building in the future?
I would say yes and no. So yes, to the extent that we, and this is not just Macomb, but all of the PIHP CFOs have had conversations with Milliman in the department, that we believe that their rate reduction due to the fact that they're assuming eligible increases is probably too optimistic, right? We think that they're too optimistic from that perspective. So what we've done is we've provided them feedback that if or when the public health emergency ends, you will need to recalculate that rate reduction very quickly, right, to compensate for that. And at least twice we've gotten them to, verbally confirm, yes, as soon as we get notification from the feds that the public health emergency would end, which the feds have provided the guidance that they will give 60-day notice at minimum, 60-day notice before they will allow it to end, they would start the rate recalculation process. So on that point, we are advocating strongly for Milliman to be prepared to fix that, what I will call a problem. That being said, because of that, rather than budgeting about a 1% reduction in revenue that we would have budgeted, I'm budgeting more like a 5% revenue reduction in case they don't fix that timely. So I'm trying to be a little bit more conservative in the budget and plan for the worst and hope for the best is kind of where I'm at.
Got you. One of the concerns that I have, and it's more with Millman than it is with you, obviously, is the assumption that as the number of eligibles go up, the percentage of eligibles that are using services will go down. There's no reason to assume that, particularly if we're successful at increasing the penetration rate, but even if not. And secondly, the increase in the eligibles will go down with the end of the emergency because they'll have to reapply, they'll have to requalify, they won't be automatically back in anymore. Is Millman taking any of that into consideration, or are they just being?
So we talked about it at length, and they said, well, here's what happened in the past. We assumed that the public health emergency was going to end, and we were wrong, right? So they're like, we really want to take one of two approaches. Either A, we assume that the public health emergency is going to end at the very beginning of the fiscal year, or we assume the public health emergency stays in for the whole fiscal year. And really one of the reasons that they want that is because then if they do have to recalculate the rates, it makes the recalculation a lot simpler, because then it's just, okay, we had it in for the whole year, not a part of the year, now we need to adjust. So, you know, we don't like where they landed in that decision-making process. We would have liked them to consider it to end earlier rather than later from a rate perspective. But I respect why they made the decision that they made, and we're just going to keep an eye on when the public health emergency ends. We will be right there to remind them, you need to recalculate these rates right now, or else we're going to have a revenue problem. So.
Right. But you end up having a revenue problem even if the emergency doesn't end, because your eligibles because they're pulling your rates down simply because the eligibles remain constant or go up.
Potentially, yeah.
Yeah, let's talk about this again.
Sure.
Okay, I mean, it's really not, but it's another argument with Millman, is what it comes down to, and that's a concern, because I thought, a lot of us thought with what's been going on recently that the prejudice, if you will, against the larger PIHPs was diminishing in the recent years, and it sounds like it's rearing its ugly head again.
Yeah, it's hard.
I don't that's rhetorical. I don't expect you to be able to resolve that problem. I mean, that's not really your job, but it is a concern that I think we're going to have to deal with.
Yeah. Yeah, and I guess my big point there is that I see that exact same concern, and to the extent that I can try to look into the crystal ball and see what the potential negative impact is, I tried to be conservative in this budget. So I guess to wrap that up into a nutshell, I think the risk is very low that we would get to the end of 2023 and feel like we've ran out of revenue. I don't think that that's very likely at this point. So, all right. Moving on to page 4 and 5. Now we're just looking at the mental health fund part of the total budget. So on the mental health fund side, total operating revenue about $244 million. Again, the majority of that is $206 million in Medicaid, $18 million in Healthy Michigan, that $7.4 million in the state general fund. And so we're looking at that being sufficient, again, with some provider stability, some continued GF spending plans that we've had from 2022 carrying over into 2023. We expect that revenue to be sufficient to cover our spending in that fund of $244 million as well. Page 5, just so that the board is aware, is the same information as page 4. The difference between the two is page 4 is in the format that you see every month in the monthly financial statements. Page 5 is in the format that the county presents to the county commission. So I just wanted you to be aware that this is the same information, but wanted you to be aware of what you're approving, because if it does look different when it's in the county CAFR, or ACFR, sorry, if it's in the county ACFR or in the county's budget, why it looks a little different than what's on page 4.
If I could ask one question. On page 4, the drop in the Healthy Michigan revenue from 22 to 23 percentage-wise is pretty extreme. Why? I realize you're being as careful as possible on the revenue, and that makes sense. As you say, plan for the worst, but hope for the best. But that's the 90% program, and why, as opposed to I expect with the decrease in unemployment rate that the reimbursements will go down once we get past the medical emergency on the Medicaid side, but it doesn't on the Healthy Michigan side. Why is there such a large
such a large decrease. So when I mentioned that, you know, Milliman was anticipating this large increase in eligibles, right? Most of that is in the Healthy Michigan population. So when they rebased the rates, most of the reduction was in the Healthy Michigan program as well. So when we go and push them to say, you need to recalculate the rates, most of it's going to hit that Healthy Michigan line. And I think the reason for that is because some of our other eligibility, like our individuals that are disabled or aged or blind, though that's a fairly stable population, and so they're expecting much less change in eligibility from year to year. So again, because that's where they assumed we would have a lot of people, and I'm kind of saying I don't agree with that assumption right now, that's the line item that took the biggest adjustment in the revenue, yes.
Yeah, I think we should have some lengthy discussions about maybe with the Legislative Policy Committee getting involved with the legislature on the rebasing, because again, I think it's hitting us in an unfair fashion.
All right. So that was page 4 and 5. On page 6 and 7 is similar, but now we're talking about the substance abuse fund. Again, for 2023, we're budgeting $23 million on the revenue side. We're budgeting $23 million on the expense side. Again, the larger, you actually see an increase on the Medicaid side, and the big decrease is on the Healthy Michigan side. Same reason in the SUD fund as it was in the mental health fund. That Healthy Michigan line is where kind of that assumption is that I'm being conservative on. And again, most of that's running through the provider network line item. So, and again, page 7 is just the same information, but now in the format that is going to be provided to the county for the county's budget. So obviously there is a chance that this could have a little bit of tweaks that happen between now and when presented at the full board. Again, unless it's significant, I would not plan on making an amendment to the budget. Obviously, if there's any feedback from the board on things that you do or don't like within the assumptions that we've made, you know, we'd like to take that into consideration. But again, if there are any other questions or concerns, this is the proposed budget that we're requesting for you to move to full board.
Go ahead, Phil.
Thank you, Chair. Hi, Richard. A couple questions for you.
Sure.
On the mental health fund page, basically pages 3 and 4, under other revenues, the $2 million-ish jump from 22 to 23, and then it kind of stays stagnant at that 2.3 level. How did we get there? What constitutes that jump?
So that's the consolidation of that grant fund into the mental health fund, and so we have that under the other revenues. Some of that has to do with the CCBHC piece of that's a little different. So we ended up putting that in the other revenues category for 23 going forward. So.
Okay, and then another question, the proposed Raymond contract that's coming, is that included in this?
We have included a placeholder for that contract in the budget at the contracted amount.
Okay, and then you've already run this through county finance and worked with Smeagol, or is that after us?
We met with, well, I should say Ken and Dave met with Steve Smeagol and with Al Lorenzo earlier this week and ran through this proposed budget. And as far as I know, there were no objections as presented.
Okay, great. Thanks, Richard. Thanks, Chair.
Go ahead, Nick.
Just when I was concentrating on the revenue side, on the operating side, just let me ask one question. You're assuming that the increased rates that we've adopted and the increased pay to direct care workers and everybody else will continue regardless in this proposal?
Yes, at this point, we did assume, again, because we're not sure exactly when the public health emergency will end, and because we have tied some of those rate adjustments to 6 months after that. So that's, at this point, I would say at least July and likely the whole fiscal year, we thought the conservative approach would be to assume that those will stay at the increased rate for the entire fiscal year.
Okay, thank you.
Go ahead, Dave.
Nick, as follow-up to your comments, the Bob Sheehan at the association, they've been meeting with another actuarial firm for the intent of kind of aiding Richard and the CFO group in pointing things out to Milliman when we have concerns on our side. So those meetings are moving along. I got a summary, email summary earlier today. There might come a point when there's an ask for some additional, for us to contract or to assist the association in contracting with the firm at a larger degree. But right now, those talks are going on for that intent purpose, that specific purpose of looking at how Milliman gets to the numbers that they get to from a different perspective. And then as Richard indicated, Ken and I did meet with County Finance yesterday. Richard and I will be presenting to the Board of Commissioners, I believe October 15th in the afternoon. I might double check.
We meet almost every day in October.
So one of those days in October, so thank you.
Okay, any other questions for Richard? Bill?
I forgot something. Sorry, Chair. Richard, on the page that the Board of Commissioners sees, the internal services line item from 22 to 23, it goes from 2 million to 400,000, and then it sticks around that $450,000 level. Where did that all shift to? Page 5.
That internal service number has to do with some of the internal charges that we have related to the county. I'll have to go double check those. I want to verify. I think some of it has to do with how we're funding some of those internal services. So some of those chargebacks are going to change. When we move to standard cost allocation, there are some things that are done via what's called journal entry between the general fund and the mental health fund. And now most of those are supposed to be moving to invoices. So county finance will actually invoice us and we'll pay them out of AP. So I believe that those are transitioned now under contracted services since we're paying it as an invoice, but I can verify that with Ken.
You might want to have that prepared just in case. I'm sure a commissioner will catch those big discrepancies that pop out.
Absolutely.
Usually get questions. And then just so the board here knows, tomorrow at our Board of Commissioners meeting, we have an ordinance that we are going to approve that'll cover us for the rest of the year because CMH fiscal is October 1, the county is calendar, so we will be doing that so we can continue what we're doing until January 1st. Thank you, Richard. Thank you, Chair. I'm done. For real this time.
Okay, any other questions for Richard or any other discussion? Okay, we have a motion and support. All in favor?
Aye.
Any opposed? Okay, thanks, Richard. Item 5L, I'll take a motion to approve to CMH full board for final approval, the MDHHS SUGS 2022 Amendment 3.
So moved.
Okay, Dave?
Helen's smiling, so I'm really tempted to call her up to the podium. But I won't. If you notice the effective dates of this are the interesting parts. This goes back to October 1st of last year and ends the end of this month. So they're cramming amendments in right at the end of the fiscal year. But this was a good amendment. It was a budget amendment, basically. So additional monies went in to the state opioid response line item. Yeah, so these were all under Helen just nod, under the substance use grant headings.
Treatment and state disability fund.
Thank you. Additional funds, kind of a settlement issue on the state side to push these through.
Okay. Any questions or discussion? All in favor? Aye. Any opposed? Item 5M, I'll take a motion to approve to CMH full board for final approval, the Raymond contract. Okay, Dave?
This has been a long time coming. A multi-year process, lots of back and forth. This has gone through legal. This has gone through county finance, and the office of the county executive have been involved in the negotiations. I'd like to thank Tracy Smith as well for helping with the contract review. So what you have in the packet is 3 attachments. One is you've seen before and you've actually approved it before, is the revised organizational chart specific to the finance department, which is included by reference in the Raymond agreement. Then you have the governmental contract language, which is the boilerplate from Raymond. Again, that's gone through legal review. We did tweak it just a little bit between all parties, and you have the final approved version in your packet. The scope of work is the one that really is the meat of the agreement. So we are looking at a multiple year agreement, which has been the goal from the beginning, to solidify our working arrangement with Raymond to provide some stability to our finance department. To be clear again, we are continuing to interview for the finance director, future CFO position. I believe I have an interview scheduled for later this week or next week. They have a search firm they're working with on the county side, and as they find applicants, those continue to come over to me. The plan is for us to continue to try to identify a lead person who would be a county employee internally, then to build the bench strength of our finance department in conjunction with Raymond over this period of time. And then if we're able to identify somebody and they're able to learn the complexities of our system, which would be a task, a multi-year task, then we'd be able to, over time, possibly reduce the dependency on Raymond. But for right now, you've heard the budget presentation, all of the acronyms and the fund sources, and working with Milliman and the changes at the state level. Our system is very complex, and we are benefiting greatly from our partnership with Raymond. This contract allows, like I said, for more stability over time. So the goal is I could tie Rachel with and informatics with the additional work on the finance department side. When the public health emergency ends, we do need to be ready for that. The Medicaid eligibles will decrease, our revenue will decrease, and we need to be very adaptable and be able to make sure we're spending the money appropriately and that we're tracking it closely. So finance and data are going to be key to our future going into probably the end of next fiscal year. So I do recommend approval of this contract, and I'm happy to answer any questions.
Any questions? Selena?
Okay, I have a question about this. Raymond has been in here, and we have major holes in our finance department. And you're stating that over time, we're going to be filling them. When do we pull the plug on the overtime? Because he can't be working at a deficit as we get into more and more of what we're doing, and the CCBHC is flying. So is there like, if we recruit for 6 months, he steps in and helps fill those empty spots, or is that an open end at the end of our contract?
That was a big part of all of the discussion, especially at the county executive side. So what we've done is we've built in language to protect us, that Raymond won't be able to hire any of our staff. We recognize the issues, and actually the Office of the County Executive was very helpful in getting movement specific to these finance positions with the goal of having them move forward by the Labor Day. There was a little bump right at the Friday before Labor Day Monday. That's been resolved. We did just complete the interviews for the finance administrator positions, and I believe we had 3 really good candidates. And we have 1 person in, so there's 5 administrators, 1 position is filled, and we have 3 candidates that were, the interviews went very well. I'll be able to provide updates to that shortly. We are able to, make every attempt to do that. If we have changes in our needs, which would probably be somebody at, the state would say, oh, we need this information right now, and we are, if those things change, and we know they will, we built that flexibility into the contractual agreement as well. Richard and I would meet, and we would agree on a scope of work, so hours, people, timeframes in advance, and be able to work that way too. So this contract gives us the flexibility to adapt on our side, on the Raymond side, to really meet the needs of this agency over the next 3 years.
Okay, one more question. So our county traditionally has been very lean in what we pay our associates. So that's great that we have some good candidates, but when we make them an offer on what we have traditionally paid in the past, a lot of times they don't accept the position. So are they going to be willing to work with us so that we can offer them a salary that is comparable to the community standards at this time? Or are we going to have you guys going through a lot of work for everybody to turn down the position because it's a good 20 to 30% below market?
Thank you for that. Interesting questions.
Well, because that's going to keep us a whole, and then he can't do his job.
The county, there was an article, and Andy McKinnon spoke to the Board of Commissioners, I believe. They are planning a significantly higher than historical for the county increases in January. So it's our hope and intent that we'd be able to post at higher levels starting in 2023. We make every attempt to be as competitive as possible and to let people know that up front so that it's not a bait and switch where we're interviewing people, putting them through this process, and then going, oh, by the way, this is your... we're very upfront with that. So we've never had, that type of surprise late into the process. But we make every attempt, and we work within the county system as best we can.
Okay, thank you.
Any other questions or comment? Okay, there's a motion and support. All in favor?
Aye.
Any opposed? All right, let's move on to item 6, receive and file. Item 6A, a request to receive and file CBH 2022 Amendment 2. Do we motion these? Or do we?
Receive and file. A, B, and C.
Okay, A, B, and C. Do we talk about these or we just vote? You want to touch on them, Dave?
Yeah, the A and B were, again, contract amendments. A is to our CMH contract. B is to the PIHP contract. Again, all primarily on the revenue side, and those were increases. The contract attachments to the PIHP contract were changed and updated in some of those cases. I've pulled all those up. I've shared them with the leadership team. We need to make sure we're aware of those changes, and tracking them appropriately. Because of the timing issue of these, they were discussed with the leadership team of the board, the executive committee of the board. They were signed by myself and the office of the county executive in between meetings, so they're being brought forward now as receive and file.
Okay.
And it was the time crunch issue, the state saying we really need this signed by this date.
Phil?
Thank you, Chair. And I'll attack item C, because that was not unique to CMH. I guess purchasing department for the county received a notice that we had 12 hours to let them know what kind of vehicles we wanted and how many we wanted. So Dave's frantically emailing me, I have to have this in by the end of the day. I just got this morning. And I went, oh, great. But we did have the director of purchasing come into a board meeting, a board of commissioners meeting this week. And he was pulling his hair out because that's not how he operates. That's not how any of us in the county operate. It's just sort of a result of the environment right now. But thanks to Dave being around and answering that day, we are in the queue for hopefully 2 vehicles. There were about 5 or 6 other departments that ordered vehicles as well. And I guess we kind of dropped the ball on some of the police vehicles, the sheriff's department, because it was a lot to get together in a short amount of time. So as a county, we're trying to avoid this from happening in the future. So as Larry asked us, if anybody has any brilliant ideas to help with this situation, let them know. Let me know. Let us know. So thank you, Chair.
And thank you, Phil. You covered that really well. And I would like to thank Tracy as well. So going back, I believe it was last fiscal year, we had budgeted for fleet upgrades. Mm-hmm. And we really needed those, and we were going round and round trying to get approval from the county side of the budget and try to move that forward. Kind of late in the game, I learned there's actually a special account for fleet. And Richard helped me. So it's more like a revolving account. So it doesn't hit our budget specifically, like the whole dollar amount of the vehicles that we were purchasing. So we had our fleet upgrade kind of wish list set and ready to go. Tracy had helped, and we were able to upgrade our cars for our assertive community treatment, but we had the vans were nowhere to be found because of the supply chain issues and stuff. So these vans are for Clubhouse, primarily, I think 1 or 2.
ACT, 1 Clubhouse, 1 ACT.
Okay. ACT is assertive community treatment. It's able to help transport people to primarily to come in, get the medication injections that they would need, or to see the psychiatrist. And then, of course, our Clubhouse, their van had been older and in need of upgrade. So we were set, thankfully, and when this became available in that 12-hour window, yeah, Tracy was calling and texting, and I was following up, and thanked the board very much for their flexibility and us being able to say, yes, please, we would like these. We do not have them yet. They're, but we're on the list. We'll see what happens.
I believe it's summer of 2023.
Yeah. So we'll see what happens.
Any other questions or discussion? Okay, all in favor of receive and file items A through C?
Aye.
Any opposed? Okay, item 7, resolutions. I don't believe we have anything. Item 8, other possible agenda items. CFO update.
Good evening again. So the CFO update is the June monthly finance report. Again, I appreciate your flexibility for letting me delay the report from the last board meeting. And I will let you know that July is coming at the next board meeting. So I really only have one thing that I wanted to highlight, so I'll keep it relatively brief unless there's other questions that the board has. You will see that page 4, which is our summary of revenue and expenses by fund source, is now page 4 and 5. So we've added a couple of sections to those pages, and I just wanted to walk through those for the board. So we have our normal Medicaid and Healthy Michigan sections, which are the first 2 segments there, but now we've added a CCBHC Medicaid section, a CCBHC Healthy Michigan section, and then now on page 5, we have a CCBHC non-Medicaid section. So here's what I'm going to tell you about the CCBHC sections is that we are in ongoing discussion with the department on how we're actually going to cost settle CCBHC. That is not finalized yet in writing. When I prepared this financial statement, it was based on a preliminary draft policy that the department had issued, and so I wanted to see what was that going to look like in our financials, so I wanted to do that preliminary calculation. Last Friday, we met with the department. The PHP CFOs gave feedback to the department on things that we did not like about their policy. The number one issue that we provided to them is that individuals who are considered mild to moderate are not traditionally the responsibility of the PHP. However, under CCBHC, we are required to serve them. So our big push and our big advocacy with the department was anyone that's classified as mild to moderate, definition not yet solid on that classification, but anyone who would be considered mild to moderate really should come out of supplemental state funds that are available to the PHP, not from the revenue that we traditionally would have gotten. The department has verbally agreed that they appreciate our feedback and they agree with that position. So that will change these calculations from June to July if I get actual written guidance from the department. So I don't know if I'll get it into the July statements for 2 weeks from now. I don't know if it will be for the August statements for next month, but we're in that conversation. So just to give you a little bit of what these new sections look like. So under the CCBHC Medicaid section, there's a base capitation revenue line item. So based on this calculation from the state, we actually move some of our money from our regular Medicaid section up top down into the CCBHC. So there's a portion that we have to pay for. And then there's a portion that is supplemental revenue that the state gives us. So that's extra Medicaid or extra Healthy Michigan that they give us on a monthly basis. And so we've calculated that, but again, those numbers might change a little bit as we go forward. The 2 other lines that are now available is the expense line, so we actually calculate what our actual cost of service is, and then also a surplus or deficit. So we are actually at risk for CCBHC. If our cost of service is higher than the revenue that we're allowed to earn, we have to use local dollars to supplement that. If our cost of service is less than the revenue that we earn, we get to keep that as local dollars. At this point, based on this formula, it would look like for the CCBHC Medicaid program that we have about $7 million of surplus that we'll be able to keep as local dollars for 2022. And on the Healthy Michigan side, about $1.2 million that we would be able to keep as local dollars. So again, those numbers can change. I want to stress that. Those numbers will probably change, but preliminarily it shows us that our CCBHC program is not costing us additional money. It's making us a little bit of money. So that's good news, because I would say for the first 9 months of the year, my biggest concern is that without guidance from the state, we had no real compass on whether or not, okay, is this program financially sustainable or not? So if there's one takeaway from my finance report is I do believe that the CCBHC program is financially sustainable, and that's good news for us going forward. So that's my big highlight for June. Again, July's report will come at the board meeting, but if there's any questions about that, I'm happy to address that tonight. All right, thank you very much.
Did you, were you going to talk about this MI Health Link, or is that?
That's under mine.
Okay, never mind. Thanks, Richard.
Yep.
Okay, Dave, you're up. CEO update.
Do you need to, oh, no, okay. Well, good evening, everybody. I'd like to start my report by welcoming Tracy Smith up to this group. I submitted the paperwork for Tracy to become our interim Chief Operating Officer. So it's been formally submitted, and we'll hope to hear back from HR on the official process. So yeah, welcome, Tracy. And as you've heard, you know, throughout the presentation tonight, Tracy's name has come up frequently. She is very involved in numerous areas on the operations side. I'm now meeting weekly with Tracy and Stacy. Used to meet with Adam and Tracy and things like that. But we've looked at the reporting structures internally. And with 1 week, a week and a half now, I'm busy. But, and I'm sure lots of people can say that, but we are operating very well still, as we will continue to post and look for the Chief Operating Officer position. Also on the staffing side, I'm very happy to report. I checked today. We had, I was involved in the interview process for the Assistant Corporation Counsel, who would be primarily assigned to us on the CMH side. The job was offered and was accepted by Linda Penty. Linda is scheduled to start on Monday, so very happy. I heard from John Shapka today. Linda comes with a really good background and experience specific to community mental health, to a lot of the areas, jail health services, veteran services, public health, FOIA, compliance. She has a good background in all of those areas. It is her intent, I believe, from our interview process. She will, of course, meet the board here, probably will attend some of the board meetings. She'll be very involved in our day-to-day and the orientation process, learning about our systems. But the fact that she comes with a knowledge of the community mental health system is just a huge plus and benefit. So look forward to you all meeting her. Been sharing a lot of information with the board as well in between meetings. The recipient rights article sparked some good conversation, I know, amongst the board members, internally as well. There is Bob Sheehan at the association has been responding, sending information to the folks, the leadership at the Michigan Department of Health and Human Services. The fact that Macomb came out looking well is a plus, but that, you know, I always feel bad about saying, you know, our revenue is up during the pandemic, because it's a pandemic and, you know, people have died, and it's kind of that same thing. You look at what's happened to some of these people, you know, related to the recipient rights issues. So we are looking, I talked to the leadership team and to Kathleen in marketing. We will be doing some marketing and outreach efforts specific to the importance of recipient rights, of speaking up, We will be making sure, Tracy's really helped with our back to work plan. I know it's come up here before too, but we need to make sure people are out in the community, that they're checking on people face to face as much as possible, to reduce the likelihood of some of these really horrible things happening out there in the community. So we did take that article very seriously. We did not sit back on our laurels one bit, but I would like to acknowledge the hard work and dedication of our rights department. When you look at the numbers, really support that we have fewer FTEs, but we do more investigations. People are speaking up more here in Macomb County. When Jennifer Dixon, the reporter, her first voicemail was, she wanted to speak to me about how aggressive our rights department was. I'm like, that doesn't sound good. So I didn't pick up the phone, call her right back. She reached out again, and we did have a nice conversation, and I clarified that comment. So like I said, there was some good news on our side, but you know, things are happening statewide, and we do need to always keep that in the front of our mind. The other article came out in the Macomb Daily, and Helen touched on it very well too. We are paying a lot of attention right now to our crisis continuum. The article in the Macomb Daily from when Vicki Wilbur presented to the Board of Commissioners really summarized and highlighted those activities very well. Again, we are in a position of benefiting from those revenue sources, the ARPA funds, the opioid settlement dollars, the Medicaid general fund dollars, and all of those things right now. We are, I've toured the Juvenile Justice Center numerous times now. I did finally make a connection with the Michigan Department of Health and Human Services just Monday afternoon. I was able to talk to them. I will now be an active part of their crisis stabilization unit conversations going forward. If you recall, when the state budget came out, there's I think $100+ million specifically earmarked for crisis stabilization units. Detroit Wayne was a separate, and they are scheduled to open up their crisis stabilization unit early next year. There's been some press releases and things like that. But there's, you know, in addition to all the other money I said, there's money earmarked at the state level. I made it clear to them that we were very interested here in Macomb, and that we had a lot of resources already available to us. The fact that we are the CCBHC, in addition to the PHP, Cmhsp, opioid health home, everything else, is really beneficial when you're trying to build this continuum. So I'm describing it as a hub and spokes. The hub would be a crisis stabilization unit, a 24/7 place where people in crisis could go. Again, reaching out, connecting to the police departments, the first responders, but also having the ability for people and family members to access those services as well. The jail diversion would be a part of that. And I have in my office now the blueprints for the Juvenile Justice Center, and it's covered with Post-it notes about all the various programming components that we might be able to use there. Do need state approval, you know, in order to stand up something like that in that type of facility. So that's where I'm spending most of my efforts right now. So I gave them an open invite for a tour, and I will continue to follow up on that and continue to provide updates to the board. Because we had some free time, Helen and I been working a lot on that crisis continuum, all of these EGRAM things. A grant opportunity came up from Andrew Cox, he's the director of the health department. And again, it was looking at opioid overdoses and with a primary focus on data sharing. It's up to a $300,000 grant from November of this year through July of next. But we are going for it. So it's due Friday by midnight. We've met a few times now. We're working on doing the actual writing components for it, pulling those pieces together. The good news is the mandatory requirement is data sharing. And then there's about half a dozen other areas that are optional, but all of those other areas are things that we're already doing. So we get to kind of say that, you know, outside of this $300,000, we're already doing all of these other good things related to substance use, thanks to Helen and her efforts. So I think we'll be able to, you know, produce a really good product application going into it's going to NACHO, the National Association of County Health Officers. There's 2 C's, I think, in there, is the agency leading this. So we're working on that between now and Friday. Other grants came out. I was on a kind of pre-bid conference this afternoon. The state's issuing a grant opportunity for a Children's Crisis Stabilization Unit. When I talked Monday afternoon about the crisis stabilization units, they are focusing on adults. But in conjunction now, just today, they're also looking at crisis stabilization services specific to children, and that's under the My Kids Now project, which is what the state did in response to their lawsuit, the KB lawsuit, where the state settled and formed the Children's Department, and there's hundreds of millions of dollars special earmarked for children's services as well. So again, crisis stabilization, Helen mentioned keeping people out of the emergency departments. So on that note, I've met recently with all of the big health systems here in Macomb County. McLaren actually made a connection with the Macomb County Sheriff, Anthony Wickersham, about maybe doing a community forum with first responders, our health system partners, and the CMH about issues related to the emergency rooms. So they recommended that. It made it to the Office of the County Executive. They're in favor of that. Kathleen from my shop is helping, and we've met with Planning and Economic Development, those folks too. So we'll hopefully be formalizing the details around that community forum. It'll probably be at Macomb Community College or the Macomb Intermediate School District to spark some good conversations about what the first responders are experiencing, what the health systems are experiencing, and then we'll be able to share things that we're currently doing. We have made some changes. We do have our staff in those emergency departments more than we did previously to improve the communication and the responsiveness to those people who need to be reconnected to the community, transition out of the emergency departments, who are stuck for any number of reasons. And then this crisis continuum stuff that I've touched on too. So we'll be able to go into kind of our future planning as well. That gives me to the My Health link. So any questions about anything I said so far? All right. My Health link, sorry for the late addition to the PowerPoint. My Health link is the dual eligible program that the state started. Dual eligible is people who have Medicare and Medicaid insurance. So I give you a brief background going back to 2011, when Michigan worked with the federal government to get this program started. Again, it's a care coordinator. It's working with physical health and behavioral health. In Michigan's model, they created, again, acronyms. The Medicaid health plans became, I always know this, care organizations, ICOs, integrated care. Yeah, yeah. So we work with 5 of the Medicaid health plans called ICOs. It's Aetna, AmeriHealth, HAP, Meridian Complete, and Molina Healthcare. We are subcontracted under those. So usually we're at the top of the funding stream with the Medicaid, Healthy Michigan, all of those. In this program, we're subcontracted under the Medicaid health plans. We've been running this for a number of years. The contracts are set to expire the end of the calendar year. The state's looking at this program, and they might be making some changes as well. Southwest Michigan Behavioral Health has already issued official notice that they're not going to renew the contract. The state has asked us, all of the, I think there's 4 pilot areas statewide that are working with MyHealthLink, the Upper Peninsula being one. Southwest, like I said, has already given their notice that they're backing out. When I reached out to our staff, you can see that the pros were a couple of things, that the cons were multiple pages. It's an administrative burden with really very little beneficial outcomes. And the other thing that I really want to stress with this is that if we don't continue the program, we don't anticipate any negative impacts at all on the people getting their services. Especially now, since we're the CCBHC, we do have care coordination stuff available. We do have the integrated healthcare services. On the financial side, we've actually losing money in that line item. And for purposes of protocol and precedent, I was simply not sure if we choose to let a program go, what the board's preferences in this area would be. If you would like to be notified, if you would like to do formal approval. If so, we can get this on the agenda for the full board meeting at the end of the month. But my overall recommendation in summary of all of this information that you have is that we provide them the 90-day notice that we don't intend to renew the contract going into 2023. Linda?
2 concerns. First of all, when the program started, it was very confusing for the people we serve to sign up and get enrolled and who their provider was and what the coverage was. So getting out, I wouldn't want to see that be confusing to them either.
Yeah, I really don't anticipate, because you can see I included a chart of the number of people that we're sharing by integrated care organization. It's overall pretty low numbers. It's in the hundreds. We will be able to, the folks that are currently active within that program, we will be able to communicate with directly. Their services on our side won't change at all. Whatever they were getting from us, they would continue to get. We're able to bill Medicare. We would continue to provide those services. So it's more letting the administrative side go. And I should say, on the provider's behalf, when you talk to providers, they frequently will speak up about the administrative burden when they're working with numerous PIHPs or CMHSPs. I don't want to let the irony of that go by without acknowledging it, that yes, we're saying when we're dealing with numerous contracts from these 5 ICOs, it's complicated from the quality oversight, the reporting aspects, the overall contracting, the cost settlement pieces. It's a lot of work. I should also acknowledge Carrie in our office, who has made clarity out of the chaos of this process. There will be no negative impact on our administrative staffing or anything else. It would just be letting this program go back to the state.
So I have a question. I'm not envisioning how this happens. So now their carrier is, like I have Medicare, I have Blue Cross or whatever. So their carrier is Aetna or Meridian or something like that. Who will be their carrier? People like their insurance card in their wallet, don't they? Or is that
They would
one of the
continue
many
to
things
be,
people no longer do
they
that I
have
do?
Medicaid under a Medicaid health plan, and then any services that we had been providing through the My Health Link program, we would simply bill directly to Medicare if it was one of the Medicare covered services.
And to your question, this is probably, as a board member, my opinion would be that this is something I'd probably like to know, that you're, a program that you're changing.
Yeah, so I'm bringing it as informational today. If you would prefer, if it's the board's preference to make it an action item, we do have the ability to, later this month, to make it a official board action. And then we'd work on the notice process ahead of time so that if you did approve it, we'd be ready to go.
Because of it, what I have seen in the past so many times, then it kind of like goes in waves throughout the community. They're stopping my link, or they're doing, it becomes a really anxiety producing thing for people. If it's only a couple hundred people, no one signed up for my link, I guess.
I'm not anticipating, turmoil
Okay.
with this decision. Like I said, Southwest has already done this, has given notice that, their intent is for the program to end the end of December. I've talked to Brad Casemore, the CEO of that PIHP. He's very confident he made the right decision.
Thank you.
Nick?
I like like Linda, I remember that when this started out, a lot of people didn't opt in or opted out. I forgot which way it was. So it doesn't surprise me that it hasn't impacted as many. But is there anything that this rolls over into the CCBHC model, since we're dealing with folks who are more involved, both physically and mentally?
Yeah, actually, so our CCBHC is not a program. Pretty much it's a way of doing business now.
Right.
So these individuals would definitely be part of our CCBHC services going forward.
The intent of the MyLink was to try to, the irony of the MyLink is when you compare it with the Shirky proposal, this basically was a pre-Shirky type of proposal that put the health plans on top, and so its failure shouldn't be lost on the department or the legislature.
Donna?
That's always a possibility, yes.
I would support bringing this to the board as a proposal, but could you also, when you bring it to the board, let us know if there's any impact on any of these people in any increase in what they have to pay in their insurance costs? If they have a copay because of the change or anything like that. I don't know if that'd be possible for you to do that assessment, so that we would know that at the
Yeah,
time when we'd
the
be
one
voting.
pro was no copays or out of pocket. So I can maybe look at a sample of some of the individuals and look at their specific situations. Yep.
Selena?
I think that's really important to know. We're also going to have to let the providers know, because now they may need to start putting a process in place to collect copays.
Under our CCBHC and with the new finance department, we are centralizing the ability to pay process at our level. So we're doing that.
Okay, so what about an inpatient stay? Will there,
Well, you would have to do that. I have no idea on the
think-
hospital side, collecting the
Yeah.
ability to pay. But Richard has I know on the outpatient
because I'll
side,
be
we're
honest with you,
centralizing.
as a provider, and it's very convenient for me to deal with one entity. But unbundling this, now I'm going to have processes in place and the hospital side that is going to look a little different because everything looks a little different.
Right. So this is a very general statement, and there's always exceptions to the rules because of third-party liability, right? So I want to acknowledge that this may not be 100% true, but the general rule that we would follow is that even as we transition from the My Health Link program into what I'll say is the CCBHC model, right? Because these individuals are Medicaid eligible, our Medicaid contract indicates that their ability to pay is zero, and so the Medicaid pot of money would continue to pick up the copay. So the expectation is that there would not be an increased cost to the consumer.
But that's on the CCBHC side. What about when they have to go into the hospital and they're admitted for 17 days?
So if they had a primary payer, like a Blue Cross or whatever, then the hospital would still have to bill the primary payer first, and then they would remit that COB information to us. And if the person had a payment requirement, Macomb would actually bill for that. I expect that to be zero most of the time.
We're going to talk.
Okay.
Because I don't want this to be, this may make it really easy for us as a county, but I don't want the burden to be on the folks that in 90 days, there's going to be a change and they're going to be scrambling and wanted to. So I want to make sure that the burden is on us to solve this without them trying to figure out how to do it in the community.
Agreed.
Yeah, no, we'll definitely look on the inpatient side and see what would happen.
Because that's where all their cost comes from. They can't pay their bills, and then they go upside down when they get into the community trying to figure out when I submit a bill to them for $3,000. I don't want that to happen to our folks.
Well, I'm very familiar with the non-My Health Link process historically, which was, you would go in, we would authorize, we're not usually made aware of a Medicare primary admission.
Right.
So we might need to set that up with the hospitals, because then we would be, we could cover the copay once that kicked in. And then when the Medicare days stopped, then we would start authorizing that under the
Right.
Medicaid
So
benefit.
I think that those are conversations that we need to have
Yeah.
before we do this, so that we already have it in place.
Yeah.
Because it's going to look a little bit different, because you're going to now be doing that authorization for that secondary, or you could be flipping in the middle of a stay as a primary. And so what is your process to get authorization for that, so that you do
Yeah.
know that that patient is in the hospital? Because we
Yeah,
don't
we can double
contact you
check
right
it,
now.
because, well, I'm sure it's happening right now with Blue Cross primary and things like that, and Medicare people who are not in the My Health Link program.
Correct.
So I'll just verify that, and
Okay,
we'll get written guidance out to our health systems.
okay. Thanks.
Thank you.
Any other questions? Go ahead.
Thank you. Dave, are you looking to have this approved before the beginning of the fiscal year? Is that why you're looking at 2 weeks, or could this go through program and budget next month?
We have to give 90 days notice, and it's set to expire 12/31.
Okay,
the contract. So we'd have to give notice October 1st.
okay, good to know. Thank you. Thank you, Madam Chair.
Any other questions? Anything else, Dave?
Nope, thank you.
Okay, thank you. Let's move on to item 8C, reminder, CMH full board meeting will be Wednesday, September 22nd at 6 PM. Item 9, hearing of the public. Is there any member of the public that wishes to address the board? Going once, going twice. Okay, hearing of the public is closed. We'll move on to item 10, adjournment.
Move to adjourn.
Support.
All in favor? Okay, we are adjourned.